So typically a superficial melanoma looks like a melanoma. The problem is I can't tell you what a melanoma looks like because every single one is unique. Now I can tell you what basal cell carcinoma looks like, I've already done that. I can tell you what squamous cell carcinoma looks like, but I can't tell you what melanoma looks like. Every single one is different from the others. I can give you some clues. So many of the flat ones are irregular in shape, colour and structure. So if we look at this and we divide a line, the left doesn't look quite like the right. So if we see this black bit here, there's no black bit on the other side. If we go that way, this is blacker than the other side. So colour's pretty important. This one, I'm not sure where this begins and ends, but the skin over there looks a bit... Do you see how it's hypopigmented? Maybe the melanoma actually starts right up there. Or maybe somebody's tried freezing it, thinking it was a keratosis. And the white is because they froze it. Who knows? And then where's the edge down here? I can't actually see the edge. I don't know where that melanoma starts or ends, but it's certainly irregular in colour, structure, and maybe shape. They're not all irregular in shape. Okay, so there's a melanoma on the palm of the hand. This lady's 90 years of age. She's in a rest home. And she was scrubbing at her hand trying to get the dirt off. That's a melanoma in situ. It's probably been there for some years. Who knows? This nodular melanoma is skin-coloured or red. So that was thought to be a basal cell carcinoma. And the patient languished on a wait list for 6 months because it didn't look like a melanoma until the pathologist got it. So melanomas arise from normal skin mainly. They don't come from moles. Only a third of them come from moles, or maybe not even that many. It's impossible to say because various reasons. Maybe it's more, but the melanoma's destroyed the mole. Maybe it's less because you can find melanocytes anywhere because they're a normal part of our skin. So we don't know, but most of them come as new lesions. They may be thought to be moles because they look like moles when they start. Most of them start growing as flat lesions and don't become palpable for a long time, and a long time might be decades. But some of them grow aggressively from the beginning. I'd just joined my colleague in practice, and a doctor came to visit me. He said, I saw your colleague 3 months ago. She gave me a thorough skin check. I am quite sure that this was not there. And he pointed to a new lesion which we excised and was melanoma. He died within 3 months of melanoma. But that's an uncommon story. So we want to cut them out when they're thin. Now the problem of doing that is an awful lot of melanomas are suspected because somebody comes to you and says, is this okay? And you've heard my story. And you say, I don't know, let's cut it out. And in general practice, there are doctors who will remove 100 benign lesions just so they don't miss melanoma. Well, they probably missed lots of melanomas because if they're that bad at diagnosis, they don't know what a melanoma looks like, and I've already told you they're tricky. So we believe that excision of lesions suspicious of melanoma should be done by a limited group of people who are trained to do it, rather than everybody who needs to. And later on I'll be telling you how we are dealing with that in the Waikato. So these rare type that grow, as you heard, we removed that melanoma in this doctor at the earliest possible time, and yet he still died. So we may not be able to prevent all deaths from melanoma, but we have to try. It's the fourth most common cancer, and it's the most common cancer in younger adults. Most melanomas are diagnosed in people over 40, but a few are in younger. More diagnosed in males than females, and more males proportionately die than females. And there are reasons, but actually we don't know why that is. If you've already had one, you have about a 1 in 10 risk of a second one, according to world statistics. But don't come and live in the Waikato, because our statistics are if you've had one, you have a 1 in 4 chance of developing a second melanoma. On Wednesday, I saw one of my favourite patients. She said, I've just had my 9th melanoma removed. So I chalked this up and gave her an examination. Now, a skin examination takes 3 minutes. It took me 25 minutes in this patient, and I diagnosed 4 more melanomas. I'm sure they're melanomas. She's unusual. So she'll be one of these ones who has a genetic predisposition to them. And she's now in her 70s, so her immune system's wearing out, so they're accelerating in number. But she's still alive, and she had developed her first one in her 20s. So we see her every 3 months for a thorough skin exam. So UV levels are highest at 130 in the summer. So we need to encourage our patients to avoid being outdoors in those times, even when it's raining, and to wear fully protective clothing. Now, sunscreens are useful, but they're not nearly as useful as gloves. And sunscreens are messy and sticky and expensive, and even if people tell you, oh, I always use sunscreen, they won't be doing it according to the instructions, which are reapply every 2 hours thickly. Nobody could do that. It'd be horrible. So we don't like sunscreens because they're sticky, they sting, especially in your eyes, they look ugly, they're expensive, they come in confusing numbers of different options. You know, you can get a lotion, a gel, a spray, an ointment, a paste, what do you want? The thing is, you want to look for the number 50 plus, and that they're not allowed to put that on unless they're broad spectrum. So what does broad spectrum mean? It means it covers UVA as well as UVB. Why is that important? Most sunburn is due to UVB, but 10% is due to UVA, and there's an awful lot more UVA than UVB. There's UVA all day, whereas UVB is only in the middle of the day, and UVA is 100 times more prevalent. It's not as strong, but it goes deeper into the skin. And UVA suppresses our immune system. And even SPF, broad spectrum, 50 plus sunscreens do not protect us very well from UVA. So the rays get through and suppress our immune systems, which are already damaged because we're older or with sun damaged, and allow cancers to grow. So when my transplant patients come to me, they're already immune suppressed, so they know about immune suppression. And we talk about this, and I say, sunscreen's not good enough for you. You need thick clothing. So thick, by thick I mean very dense. Loose clothing. Go to Kathmandu or somewhere, get clothes designed for the outdoors, light, loose fabrics that are cool, absorb sweat, and protect you from UV. And we've already mentioned about the sun alert. So the Met Service from the Enduring Daylight Saving Time does tell you the forecast for the UV index for where you are. So on DermNet we display something like, we used to display this one, we display a different one now. And the reason we changed is this one's only for New Zealand, and most of our audience for DermNet is worldwide. So we now have a worldwide UV index throughout the year displayed on our front page. Don't Does what you eat matter? Probably, but I've no idea what component of it is necessary. We mostly eat too much, don't we? There is a suggestion that vitamin B3 is required for healthy skin, but we only know that because if you give 1,500 milligrams twice a day, 1,500 it is milligrams, it's not grams, that would be 1.5 kilos of oops. So that's 3 500 milligram tablets per day. You can reduce actinic keratoses and invasive squamous cell carcinomas by about a third. So we do recommend those megadoses to our patients who are developing lots of squamous cell carcinomas or who have terrible actinic keratoses. The problem is that's not just what's in a multivite. So 1,500 milligrams is the dose, but a multivite has 15 milligrams. So we're really talking mega doses. And so you buy Blackmore's in Solar. There may be some other makes now, but that was the only one available until recently anyway. And that's an Australian product. It's not expensive. It does have some side effects and risks because it's not, it's mega doses. Exercise. Well, exercise is good for us. Does that help our immune systems? Almost certainly definitely does. So is it protective against skin cancer? Well, it's a bit of both, because if you're outdoors, you're exposed more to the UV. So we just have to be a bit careful with that. So obviously we need to think about that. So we should be teaching our older persons to examine their own skin. And on DermNet we have a video. It's a bit long, this video. I can't get to the end of it, but maybe some of our patients can. So we know that 50% of melanomas presenting for excision have been recognized by the patient or one of their close loved ones. However, those that are recognized by a health practitioner are much thinner than those ones recognized by the patient. So regular skin checks are part of evaluation of an older person. People with lots of spots are helped by mole mapping. Now, I'm biased as a consultant for Mole Map, which is the nationwide service for mole mapping, and I don't think it's useful for people with lots of actinic keratoses and basal cell carcinomas, except for those ones that don't go to their doctors regularly, where it's a alternative, I suppose, for a good thorough skin check by a nurse that's trained to do it. And but it's incredibly useful for evaluating people with melanocytic nevi, so moles, and for detecting melanomas. So I'll do a couple of hours mole mapping 3 or 4 times a week, and during that time I expect to diagnose 3 or 4 melanomas. And we catch them early because we catch them as changed lesions or new lesions. Sometimes we're quite surprised. We might have been following something for 10 years and then we think, oh, I think that's a melanoma. Because the previous 9 years, it could have been any other spot. It was a melanoma from the beginning when you look back and you think, oh, why didn't we catch it in the first year? It was a melanoma then. But maybe it's because that patient is covered with weird-looking freckles and moles and things. And the only way we caught it in year 10 is because of change. And that patient was also attending skin checks from GP or dermatologist, and they can't see change. All they can see is what we see on the day. And change is vital. Now, most people don't need mole mapping because they've got small numbers of spots. But some people, it's life-saving. So older people should be inspecting their own bodies from head to foot and getting used to what's normal for them. Their normal spots, their normal moles, their normal seborrheic keratoses, their normal angiomas, their normal whatevers. And they're trying to look for something that looks different from the other ones. A spot that doesn't belong. You've got 20 brown spots and there's a black one. Well, that doesn't belong, that black one. Or 20 brown spots and there's a red one. That doesn't belong either, especially if it's changing. However, benign lesions change too. So The commonest reason for coming to someone because you've got a changed spot is a completely harmless seborrheic keratosis. So it's really important to know what they look like too. So here's some harmless moles and harmless freckles. They all look the same as each other. Seborrheic keratoses. Now, seborrheic keratoses don't look the same as each other. They're highly variable, and many of them look exactly like a melanoma ought to look. So how do we tell the difference? It can be tricky, and we do excise seborrheic keratoses just to be on the safe side. However, they generally have a stuck-on appearance. Boom, stuck on the top of the skin, which a melanoma doesn't. They look as if you ought to be able to peel them off like a barnacle, but like a barnacle, they're stuck. You can't peel them off. Angiomas. We get a lot of referrals for angiomas because sometimes instead of being red, they're black. All you have to do is use a magnifying glass to discover they're not actually black, they're purple. And purple is blood. Basal cell carcinoma might be a sore that doesn't heal or a lump that's growing, shiny. A melanoma, asymmetry of colours and structure. D for diameter, don't take any notice of that. We want to see melanomas that are small, not big. So we like D for different, not D for diameter. So with one's mind's eye, actually just turn that into black and white in your head. Don't worry about the colours, just the symmetry. The left doesn't look like the right. The top doesn't look like the bottom. Might have a border irregularity about it, but we don't want to teach you that because so do solar lentiginase, and they're completely harmless. And the size, well, 6 millimeters was decided as a sort of more chance that it would be malignant if it's more than 6. But of course they start somewhere and they start smaller than that. So we want to catch them smaller. I think I've covered that. So if you go for mole mapping, you get whole body photographs so we can see if new ones have turned up. And you get pictures of all, not all of your moles, but the ones that concern your referring doctor, or concern the melanographer. That's the nurse who's got a checklist of things to photograph. And then the dermoscopy images. So a dermatoscope is a handheld instrument. There are lots of different types. I personally own about 14 of them. I'm very privileged because most of them I didn't even pay for. But I do a lot of research. So we've been doing comparison studies to see which is the best. Because people often come up to me and they say, which one should I buy? And I say, I don't care, because I know that they all work. And people sometimes think that if they buy the best, they've got the Rolls Royce, that should be pretty good. True. But like a Rolls Royce, you have to look after it because you don't want to lose it. It's expensive. So you're going to lock it in the cupboard, which means that you're going to forget to charge it. So it won't work when you pick it up. You're going to scratch the lens. It's very expensive to get a new lens. And they're actually, because they're so flexible, these expensive ones, your picture's going to be out of focus because you haven't got it quite right because you don't use it often enough. So actually, sometimes buying a cheaper one is better. They all work. So what's the difference? Well, we see some things in a close-up image. That image just looks like a mole with 2 spots in it. It doesn't look too serious. But as soon as we come to the dermatoscopic image, we can say, oh, this is a bit weird. This bit doesn't look like this bit, not, as well as this bit not looking like this bit. And here we got some strange lines over here. So that's an early melanoma. Treatments. Some things we freeze. Well, we freeze keratoses, so seborrheic keratoses and actinic keratoses. Sometimes we'll freeze the squamous cell carcinoma in situ, IEC, intraepidermal squamous cell carcinoma, but that's only suitable for small ones. They've got a bad reputation for coming back. We use fluorouracil cream, 5-fluorouracil cream, That's our favourite. Recent study coming out of Northern Europe tells us that it's the most effective treatment for actinic keratoses compared with the other options, and the other options are imicrimod cream, for which there's no license for it to be used, but it's used quite a lot for actinic keratoses. No, sorry, it is licensed for. It's not licensed for intraepidermal carcinomas, but is licensed for actinic keratoses. And we use ingenol mebutate gel, but that's quite expensive. It's convenient, but it's not as effective as fluorouracil cream. But fluorouracil cream has to be applied properly. So freezing requires training. Fluorouracil cream requires training too. We cut skin cancers out. And sometimes that leaves a big hole. And so various techniques are used to put it back together again. Okay, so just some other things we see in older people. Infections, they're immune suppressed, they're not eating properly, they're in areas where there are lots of other individuals, and there's transmission from healthcare staff, and mainly they're just old. Eczema is extremely common in older people, drug rashes and bullous pemphigoid. So here's a man admitted to hospital, has a rash. Well, I can't tell what that rash is. It's slightly asymmetrical, so I'm thinking, I don't think this is a drug rash, because a drug rash should be exactly the same on the left as the right. So I'm thinking, well, is it eczema? I don't think so, because, well, it could be, but don't think so. I actually think this man has a sweat rash. Because he's lying in bed and the sheets got plastic on them, and he's had a fever because he's in hospital because he's ill, and he's not getting up and about. So here's somebody who's got a surgical wound. We know that because of stitches, and he's got a bacterial infection. We know that because of the pus. But pus is not a good clue to infection, really, because you can get pus from fungal infections, you can get pus from neutrophilic dermatoses, which aren't infections at all. They're just neutrophils. You can get them with viral infections. In this case, that's Staphylococcus aureus. So 40% of people over 60 years of age have onychomycosis, which means nail fungal infection. More than 60% have more than 40% have abnormal toenails. So just because they have a funny toenail doesn't mean it's a fungal infection. There are other reasons for funny toenails. Age itself, trauma, and trauma just means hitting the foot over and over and over and over again against the tip of the shoe. And psoriasis and other skin diseases. So here's a picture of infected fingernails. Fingernail infection is less common. So if I saw a fingernail looking like that, I'd be asking about, do you have any skin disease like psoriasis? Have you had any injury to that nail? And let me look at your feet, please. So if we look at the hands, we must look at the feet, because the feet have the same skin. And you're going to find a dermatophyte infection. So tinea pedis or tinea unguium, which is a dermatophyte infection, affecting the feet and nails. So that would make it more likely that that's the case for a damaged fingernail. But I could not, from that single picture, tell you why that nail looks like that. It might be infected, it might have psoriasis, it might have been injured. The results are the same. Wound infections. Well, wound infection, incredibly, you'll know much more about wound infections than I do, because luckily they don't come to a dermatologist. But they're hugely common in older people. They're hugely common in people on systemic steroids, in people who have diabetes, who are immobile, and other predispositions. Cellulitis, one of my favourite topics, because a dermatologist never, in this country, never diagnoses or manages cellulitis. We know that 1/3 of hospital admissions for cellulitis do not have cellulitis. So let's remind ourselves how the diagnosis is made. The typical history is the fever, the rigors start first. Then the rash appears on the local area, and it's painful and it's hot and tender. If you examine the patient, they have a fever. If you were to take a blood test, you might find a leukocytosis and a raised C-reactive protein. You give antibiotics and it gets better, mostly. The 1/3 that don't have cellulitis, when you look at their history, they didn't have the fever, the rigors, the hot skin. They just had red skin. And red skin can be due to a host of other things. But we don't want to miss cellulitis, so we quite understand starting an antibiotic. But what I don't understand is, why are we on to the 3rd antibiotic and 3 weeks have gone by and you haven't called a dermatologist? That becomes puzzling. Viral infections are also common in older persons, particularly herpes zoster. Now, herpes zoster can occur at any age, including infants. It's a horrible condition. PHARMAC now pays for vaccinations in older people. I think it's 60. Anyone remember? 65, okay. But it's licensed for use, I think, from 55. And it doesn't stop herpes zoster in all cases, but it reduces the risk and it reduces the severity. And why wouldn't you? Well, why wouldn't you is because it's a live vaccine, and that's inappropriate for people who are immune suppressed. But most people, luckily, are not. So I'd highly encourage that, because this is the death toll for many older people. Shingles is the end of the line, finishes them off. I say that because that's what happened to my aunt. She was doing just fine until she got her shingles.